Everything's good. No issues. All right, then let's get started. So this first thing that we're going to go over is the microbiome question. So you guys have already gotten these questions, so I'm not going to bother with the reading of the question and doing all that. Did I freeze or is everyone good? Okay, so I'm not frozen. Okay, good. All right, so let's continue. So with that being said, in this one, they're asking you the main difference in the cell walls of something that has mycobacterium versus a gram-positive bacteria cell wall. So mycobacteria and nocardia are both acid-fast bacteria. Okay. Of the two, nocardia is weakly acid-fast, but it's still acid-fast. I have a total different MCQ one. So you didn't get this first one as your MCQ one?
The ones that you put in the chat? I have one. The woman, I don't know, maybe mine's different. I have a 55-year-old woman that comes to the physician because of intense burning pain upon urination.
Yeah. Let me see. Oh, okay. So I think those questions are, I don't know why these ones didn't pop up in there too, but that one is this. Where's that at? Why do I not have that on here? That's
But you can right there with that one. That one's good too.
This is a totally different MCQ one. How did that happen? So let me download this one too, because I want to make sure we go over this one too. So 1 second. I thought I had downloaded it, but maybe not. Must have downloaded the other one. So let me do this. Give me 1 second. Because I got both of them. Good notes. New document. Temporary. Okay. So let me pull this one up. This one. Okay. So this is your first one then. Right? Okay. Good. Okay, then we'll do these ones instead, and then we'll switch over. So in this one, they're asking which of the following virulence factors is the most likely cause of this patient's symptoms. So this patient here is an individual who presents with a urinary tract infection. Okay. And she's treated with an antibiotic, but then shortly after, she ends up getting again the infection again. Okay, so it's almost like she was treated with it, but no improvement because she later presents with the same symptoms. Okay, so with that being said, which one of these is most likely the virulence factor of this patient's symptoms? Now, on top of that, this patient has a blood pressure of 86/50. The respiratory rate is 22, right? So this here are symptoms of shock, which is also a very big thing. Okay. This patient has shock symptoms. They are infected with a gram-negative bacteria. What on gram-negative bacteria can induce shock? Yes, endotoxins. Perfect. And the one that's most important is lipid A, right? So lipid A is the most important one that can cause shock symptoms. Okay. Now, with that being said, lipid A induces things like IL-1, IL-6, and TNF alpha. And these guys collectively end up causing shock. Okay. They result in vasodilation of massive amounts of blood vessels, as well as causing clotting to occur, which is what is known as DIC. And DIC is something you will discuss later in your next CAS, okay, in blood, in hemonc. But the big thing I want to ask you now is between the endotoxin and exotoxin, let's say this patient was never given ampicillin. Would that have changed the cause of this patient presenting with shock? If this patient was never given ampicillin, would this patient still have presented with shock symptoms?
Can you hear me, Doc?
No, I didn't hear you. Now I do.
Okay. Well, endotoxin is an intrinsic factor of the actual organism, like it's part of its being. So, if the organism lice is going to get released,
yes.
So, regardless, it's going to come. I mean, I don't. Okay, ampicillin is a cell wall. Is a cell wall inhibitor for gram positive. It doesn't work for gram negative, so it doesn't make a difference in this case. It shouldn't. I don't know. Maybe I'm reading it wrong. I don't know.
So ampicillin is one that also affects gram negatives.
Some gram negatives.
Yeah, some gram negatives. So with that being said, you could possibly use ampicillin for something like this.
Yes.
But the big thing is where you touched on at the beginning, right? Where it's part of the cell wall. So if it's part of the cell wall, it's only really going to be a problem when the cell lyses, right?
Yes. Yes, sir.
Good. So if let's say you don't lyse, that means there's no shock.
Shock.
Okay. Versus if the cells do lyse, you have risk of shock. So essentially, you are treating the patient and inadvertently you increase the risk of this patient developing shock symptoms because you were lysing the bacteria, which was then releasing lipid A into the blood, causing them to have the presentation of high levels of IL-1, IL-6, and IL-8. Or not IL-8, TNF alpha, my bad. TNF alpha, which then caused the shock. Okay? Good. Any questions on that? The big thing is that you only present with endotoxins when they lyse. So bacteria have to die to get endotoxin in the blood versus exotoxins are released from the microbe into the surrounding environment. It's not part of the cell wall. Okay, that's a big difference between an exotoxin and an endotoxin. All right, good. Let's continue. Now, here's the next question. So this question here is saying, which of the following is the best explanation for including clavulanic acid in the combination medication? So what is clavulanic acid, first of all? Clavulanic acid.
It's an enzyme inhibitor.
Yes, it's an enzyme inhibitor of?
If I'm correct, it should be beta-lactamase or
yes.
not. Yes.
Beta-lactamase. Good. Good. Or the beta-lactams. Okay, good. So this is going to essentially inhibit this enzyme from occurring. Now, my next question is this. What bacteria mainly express this enzyme? Is it gram positives or gram negatives? So gram positives do express it. I'm not downplaying that, but gram negatives are the guys that are more likely to express it. Now, the reason why is because in gram negatives, you have this periplasmic space. And in that periplasmic space, you essentially are allowed to concentrate enzymes. So this is a big issue with gram negatives versus gram positives that don't have this kind of outer wall, this outer membrane, right? Versus the gram positives that allow it to concentrate the enzyme. So here it concentrates the beta lactamase, which then allows it to be very resistant to penicillins. Okay. But that being said, gram positives do produce it, but they don't have this periplasmic space to concentrate it like gram negatives do. Okay. Good. Now, with that being said, you guys already know why you wanting to give this drug, because it's a beta lactamase and it's going to inhibit this enzyme. Okay. Good job. Let me see here. What other things can I ask about this? That's about it. Okay, so here's the next question. Which of the following drugs is most appropriate for this patient? Okay, so when we see this aspect, when you're asking a question like which of the following is most likely, we got to look at various things like the history. What is this patient diagnosed with, right? So this patient has a history of renal disease. They come in with fever, they have a circular rash, clearing on the left thigh. Okay, she was on a camping trip with her son and his family in Northeast United States 7 days earlier. So his previous severe allergic reaction to penicillins and to macrolides. So that means this patient has a history of allergies to penicillins and macrolides. Okay. And has a history of renal disease. What drug would you want to treat this patient with? So azithromycin. So my question to you is azithromycin a macrolide? Yes, it's a macrolide. So you cannot give azithromycin. Ciprofloxacin is a fluoroquinolone. Okay. Tetracycline is in the same category as doxycycline, right? Because doxycycline is a tetracycline. True, right? Good. So it wouldn't make sense why you would use doxycycline if tetracycline is an answer, because they're both the same category. Does that make sense? Okay. Now, with that being said, then in this scenario, you're looking at this individual who you'd want to treat this patient with. Oh, okay. I see. I'm sorry. So this is an example of Lyme disease, right? So this is an example of Lyme disease. So with Lyme disease, you'd want to give, so the reason why I messed up on it is because tetracycline is saying all types. But tetracyclines in general, some of them cause renal issues. Right? Some tetracyclines cause renal issues, but doxycycline itself does not. So that's why it's C instead of E. Okay. Does that make sense now? So in this scenario, they're wanting you to distinguish between how tetracyclines in general versus doxycycline, and how doxycycline is unique and how it itself does not cause renal issues versus tetracyclines in general, a majority of them do. Okay. Good. So it's not Rocky Mountain spotted fever because Rocky Mountain spotted fever causes a rash on the hands and feet. But this is something that you will once again touch on when you get further down the line into the second cast. It starts on the hands and feet and then progresses towards the trunk. Okay. All right, good. Let's move on. So here's our next question, where in this example, it's asking us the drug of choice for this infection will have the greatest efficacy at which of the following stages shown in the diagram. Okay. So in this diagram, we see what is known as the bacterial growth. Well, now, this patient has various stages. Which of these stages do you think a bacteria would be rapidly dividing? The log phase, perfect, which is C. Okay, C is your log phase. And this log phase is essentially where antibacterials are the best. Okay, which of these areas are you most likely to see resistance? E, perfect. Here you're going to have high risk of resistance because they're not turning over very fast. So they're allowed to be exposed to the drug for a longer period of time, and they can then develop resistance and mutations. Okay, so that's why E is where you're going to have the highest risk for resistance for a drug versus C, where you're going to have the highest susceptibility to a drug. Okay. Good. All right. Let's keep moving. So in this question, it's asking us which of the following best describes the mechanism of action of vancomycin resistance in this organism. So why is vancomycin resistant? Essentially is what is asking. So this patient's treatment with a cytotoxic drug is begun. Over the next several days, she develops a fever. Culture develops on this. This is also very important, but this is something that you don't know yet. And isn't as important as knowing what are the treatments for vancomycin resistant organisms, but this is E. coli. Okay. So that's essentially what that one is. Okay. And what vancomycin binds to, it binds to the diala. Exactly. Perfect. So if it binds to the diala, then you have a change of the diala to the diala-dilac, which is E. Okay. Now, this is also known, and you may see this later on, as the Van A gene. Okay. If you ever see something that's pertaining to this bacteria has a gain of Van A gene or expresses Van A, then it's vancomycin resistant, is essentially what it's telling you. Okay. Any questions before we move on? Now, altered binding to penicillin binding proteins. What is this? What would this give you resistance against? Yes, perfect. like nafacillin, okay? Those penicillins that bind to penicillin binding proteins, right? So all of those guys in that category fall into this, okay? Even penicillin itself binds to penicillin binding protein, okay? Good. Beta lactamase production is the same concept, right? What about this one? Methylation of the 23S rRNA binding site. What would this give you resistance to? What antibiotics do you know uses the 23S ribosomal RNA binding site? Remember? No. So my next question is, where is this 23S rRNA binding site? Is it part of the 30 or the 50S? 50. Perfect. So this is part of the 50S. So you're thinking of the 50S antibiotics now. So if you're thinking of the 50S antibiotics, so aminoglycosides are something that binds to the 30S. Tetracyclines also binds to the 30S. You're thinking of things along the lines like linezolid. You're thinking along the lines of macrolides. You're thinking along the lines of clindamycin. Yes. There you go. Perfect. There you go. So clindamycin is one of the guys that binds to the 23S rRNA binding site, as well as linezolid is one. Good. Is chloramphenicol one of them? Perfect. Chloramphenicol is also with the 23S rRNA. Okay. Make sure you know which ones bind just so you have an idea. But that's what's going on here. Okay. Let's move on. Now, here, which of the following processes of DNA transfer most likely occurred in these two cultures? Okay. Now, in this question base, they're saying that a strain of bacteria that is resistant to ampicillin is placed in a culture containing a lytic bacteriophage. What does that mean? That means that the bacteria, one bacteria is lysing open. Okay. So as a result, there's going to be bacterial DNA. Okay. The viral life cycle is allowed to proceed to completion, and their cultures are centrifuged to pellet the cells in the cellular debris. Now, this is very important. This is telling you now that there's no viral particles in this now produced supernatant, okay, or fluid. The only thing you have in there now is DNA. Okay. Now, out of that, they then transfer this to guys that are ampicillin resistant, or not ampicillin resistant, I'm sorry. And then they find out that ampicillin failed to kill them. Now, with that being said, what is going on? There's different ways that bacteria can pick up or undergo mutations. There's transformation, conjugation, and transduction. These are the three guys that this can pathway through. So of the three guys, which one is going on here? So conjugation essentially tells you that two bacteria cells are connected together. That's what conjugation means. Okay, so we're saying transduction. Now, in transduction, what is required in transduction? If someone was to say transduction, the big thing that is required is a virus. A virus is required. Now, yes, there is a virus. See, it says lytic bacteriophage. Yes, there is a virus at the beginning, but they removed it. So now there's no virus. This is where you get into this aspect with transformation, right? So transformation deals with picking up of bacterial DNA. Right? That's exactly what transformation is there for, picking up bacterial DNA. But what's going on here is they're asking for which of the following process of DNA transfer most likely occurred in these two cultures. So compared to culture 1 to culture 2, what are the big differences? So the big difference between culture 1 and culture 2 is that culture 1 was completely resistant to ampicillin. Right? Versus culture 2 was not until you gave them DNA. So why is it then that culture 1 was essentially resistant? The reason why is because they underwent conjugation between them. So they conjugated between each other to then give the DNA to the corresponding other bacteria. Does that make sense?
Because I thought, and correct me, the
Okay.
lytic bacteriophage, I thought that dealt with the generalized transduction, whereas the lysogenic phase dealt with the specialized transduction. I understand that generalized transduction is an error in the assembly. You have pieces of back DNA
Yes.
and that are equal. And
Yes.
so with the specialized one, it's an error in the excision, and only the gene is inserted next to that site. And I guess my understanding is that with specialized transduction, they are alive, and generalized transduction is they are killed.
So
Help.
yeah, most definitely. And I'm happy that you brought that up, because that's literally the next step I'm moving into, right? Because right now I'm explaining why these ampicillin resistant ones were resistant compared to the culture that you gave it to the beginning, right? So the culture at the beginning, they had undergone conjugation to give the DNA to the corresponding other guys, right? So everybody around them were resistant. Does that make sense? So, for instance, let me draw a picture. If I have one bacteria here, he's going to then undergo conjugation to the corresponding bacteria to give them resistance, right? And as a result, the entire specimen is resistant, right? This is the basis of conjugation. Okay, perfect.
Yeah.
Now, that's why culture 1 was resistant. Now, culture 1 was then attacked by a bacteriophage. So you are correct. You are 100% correct. I'm not downplaying what you're saying. You're not wrong. Okay. So culture 1 was attacked by the bacteriophage, okay, causing them to then lyse, right? And when they lysed, just like you were explaining, right? Perfect. It's either specialized or generalized, correct? Generalized being whatever is in the environment, specialized being whatever next to the lysogenic portion of the DNA, right? So for instance, here's the DNA versus this DNA, right? In a lysogenic virus, it will incorporate itself specifically in one portion of the DNA. So as a result, it will present here. So whenever it breaks off from the bacteria and becomes lytic, these portions next to it get inserted into the next bacteria, right? That is what is known as specialized transduction. Okay?
Okay.
Versus generalized, just like you were explaining, the virus comes in and breaks this up into many little pieces. And as percentage probability, one ends up popping up in a virus, which then gives resistance to the next bacteria. Okay, so that is the specialized, just like you're saying, and it's 100% right. Okay, so we've talked about why culture 1 was resistant. Culture 1 was resistant because of conjugation. Culture 2 was not resistant until it was exposed to this new environment. Okay? Right? We got that right. Perfect. Now, from that sense, we then talked about what they then transferred from the original to the secondary system or the secondary culture, right? And what we talked about that was transferred was essentially cell-free supernatant, okay? So there's no bacteria being transferred from one culture to the other culture, right? Perfect. And then I went on further to say, in this same thing that you're centrifuging over, that there is no viral, like, so what I mean by viral particles, the centrifuge broke up resistant, aka like dead naked pieces, right? So essentially centrifuge just piles up material towards the bottom. That's essentially what centrifuges do. Okay, so all the DNA, all the corresponding like viral particles and stuff like that all get piled up on the bottom. So the only thing you get out of the supernate then are various things such as how can I say it? Such as things that are free floating. Yeah, like genomes and stuff like that. Now, in that being included, you do also transfer not the actual viral particles, like the pieces of the viruses. You don't transmit these pieces, you transmit the actual virus. Okay. Okay. Now, that means now in this next set, because this set was exposed to a virus that had killed them. That was this. This is the virus that killed them. Okay. Now you centrifuge down, and only thing you're essentially transferring over now is some viruses that are still floating around, but no actual viral particles, no little small pieces of a virus, just the virus itself. Now, you then inject that into the new one. And when you inject it into the new one, you find out that some of them had the DNA, which is where you get to transduction. You see how we went over each one of these three in this one question? We went over transformation, we went over conjugation, and then we went over what the actual answer is now, which is transduction. Okay, that's why these new culture has resistance to the drug ampicillin. I hope I didn't lose anybody in that process. So this is what is known as specialized, or not specialized, it's generalized transduction, because this is a lytic bacteria, not lysogenic. Okay? Yes, no.
Yes, I'm good. Also, I got
Okay.
a question. Also, when we talk about bacteria resistant, it just doesn't happen in the transponded. It can happen in general transduction from what we see here. Correct.
Yes. Yes,
Okay.
it can undergo general transduction. And then from general transduction, that one bacteria can then transfer it over to all the other ones to get an entire specimen resistance via conjugation.
Okay.
You see how like all of these guys are always interworking together? It's never
Yeah.
just one guy by itself. Okay, so gene transduction is random, chance of resistance and specific transaction, precise insertion of resistance. I'm not sure what you're asking on that one, but here, I'll come back to that one. So let me go over generalized versus specialized again. So generalized transduction is essentially how you have a bacteria and its DNA, okay? And in any lytic bacteria, or not lytic, any lytic bacteriophage, there you go, that's more correct. In any lytic bacteriophage, the DNA gets fragmented in the various pieces, right? So when this DNA gets fragmented in the various pieces, it causes this virus, which is also inside the same bacteria, to accidentally incorporate inside of itself a piece of the bacterial DNA. Okay? Now, this is completely random, which is why it's known as generalized. All the pieces of DNA have exactly the same probability of popping up in that viral, I guess, virus. Okay? Does that make sense so far? Okay, perfect. Now, in specialized, in this one, what's going on is you have not a lytic bacteria, or not a lytic bacteriophage, but a lysogenic one. So what's going on here is a lysogenic one is incorporating itself into the actual genome of the bacteria. Okay? And as a result, you see how there's portions that are right next to the virus genome. These portions can inadvertently, accidentally be incorporated whenever it becomes a lytic, right? Because lysogenic essentially can become lytic and kill the bacteria, right? So whenever it essentially switches and comes out, it can have a portion of the bacteria. And this portion is now the portion that sits next to where the virus is. Does that make sense? Now, how are they going to then test you on these two different things? One, they can do it in this manner, where they ask you in this question. Because this statement here tells me that the actual DNA particle that's sitting around inside of this bacteria has no viral genome. Okay? It failed to show viral cytolysis. So that means that there's no virus component of it. Does that make sense? Because if there was, then the virus would then lyse them. Correct? Yes, in the new culture. Correct. Great. Now, that then means that this option here is not possible. Because if this was a case of specialized transduction, this portion of the virus would cause lysis still. Does that make sense? Now, this here has no viral properties to it, which is why there's no lysogenic, or not lysogenic, lysing, I guess to say, lysing of bacteria. Okay? So that's why it's generalized versus specific. So that's one way they can say it, like the way they did here. Okay? By telling you that there's no viral cytolysis. The second way they can say the same thing is they can tell you that they look at the actual DNA of these particles inside of the bacteria, and they do not see any viral component. Okay? That's another way of them telling you the exact same thing, but differently. One is looking at the results of the lysogen of the lytic virus, and one is looking at the actual structure of it. Okay? Does that make sense? Okay, perfect. Now, this is a concept that's very important. Transformation, conjugation, transduction, these three, bacterial genetics, viral genetics, which we'll get to here in a minute, are very high yield in bacteria. I guarantee you will get a question on one of these on your quiz. Okay? So make sure you understand transformation, conjugation, transduction, as well as these things we'll talk about with the viruses. Yes, specialized will always have some viral component. There's no way specialized cannot have a viral component. Great. All right, let's keep moving on. So that was that. So now we're looking at this next question. And what do you know? This is now a concept of virus genetics. Which of the following viral attributes most likely made the production of H3N1, H1N2 variants possible? So this here is essentially telling you this virus is segmented. This is very important because segmented genomes have the ability to rearrange. So what I mean by is this. You can have one virus, virus A, have A, B, C RNA genomes, and then you can have virus B having D, E, F viral genomes. And these, if they end up infecting the same cell, Here's one cell. If they end up affecting the same cell, they have the ability to rearrange or undergoing recombination. Does that make a sense?
So this is totally different from reassortment. So this is recombination here.
So recombination, in the sense that where you're getting at, is not in the sense of genomes were segmented. Okay. What you're talking about is with genomes that are non-segmented and they undergo portions of them switching.
Okay, that makes sense. Okay, thank you for that
That one is the one you're discussing.
Yes, okay, thanks.
Okay, I'm just using the word recombination in the sense of we're taking these RNA genomes and we're switching it up. I guess recombination was a poor word since you brought that up. So, like you said, in your sense, reassortment would have been a better word to say, because that falls into this same category. Now, phenomixing is where you're looking at the phenotype, not the genotype. Phenotype is what it looks like on the outside. Okay. So that example would be, you have virus A that has, and then virus B. So virus A has red genome that produces red wall. B has B genome that produces B wall. Okay. And then what ends up happening, if they infect the same bacteria or same cell, you can end up presenting with red with B genome. Okay. Or you can present with B genome with a portion of red incorporated in it. This is mixing. This is masking. Okay. Those are the differences. One has B with both B and A. And then the top one is B incorporated entirely by A. So the first one is masking. The bottom one is mixing. But it's phenotypic. The genome never changes. Okay. So if you ever see a genome changing, like the actual genome mutation, then it cannot be this masking or mixing. Okay. Good. All right, great. So with that being said, this is not phenotypic mixing. Okay. And this is once again because of the segmented genome that we discussed. All right. Nice. Now, here's our next question. This is essentially asking us, how many bacteria will there be in a culture after 2.5 hours? Okay. So if we end up seeing this scenario where there's 2 times 10 to the 2, and the time is 30 minutes, the generation time is 20 minutes. So essentially, this is telling you this. Here's my graph. Okay. We have lag time, which is time that nothing is produced. Okay. No bacteria divide. So essentially, within 30 minutes, the cell starts as 2 times 10 to the second and ends as 2 times 10 to the second. Does that make sense? Now, after that, you then get the doubling. Now, the doubling occurs in 20-minute increments. So after you get past this 30 minutes, which is half, you have 2 hours left. Essentially, how many times can 20 minutes go into 2 hours? Six. Perfect. So that means each 6. So you have 6 doubling times. That's how you end up finding the answer to this. Okay. So essentially, you'd first start out with 2, right? And then the first doubling time would be 4. So 2 to 4, right? And then from the 4, you'd then get to 8. Then you double 8. So we're looking at 8 times 8. And you end up having, I want to say that's 64. My brain is kind of dying on me right now. And then 64, you double that. I'll tell you because I got a calculator up. It's 4,096. So this is 1, 2, 3, 4. And then you do it again. 096. And so on as you go down the path. Does that make sense? Okay. Good. Because I want to say here, let me 1677. So it's 16777 That would have been for the fifth. 20 minutes. Yes. Okay. Yes. So with that being said, you end up being around this number here, which is why this is the answer for this one. By doing the multiplications going down. Excuse me. I'm confused on the math. How you got from 8 to 64, since that would be 8 squared. But from 4 to 8, it's 4 times 2. Oh, shoot. Thank you for clarifying that. I started off right and then had mixed up going down. Yeah, I had started off right. And then this is where I ended up mixing up. Yeah. So instead of 8 to 64, it would have been 16. Right? And then 16 ends up becoming 32. Good. And that's probably why I ended up choosing this one as well, because it should be 6 because the math there is wrong. because it ends up being 32, it ends up becoming 64, which is 6. And started out right, but then switched up to powers here. I don't know why I went to powers. All right, so that's that question. And now this here is the next question that goes on with the following way, that this is showing us conjugation, right? So this is conjugation of a specific thing here, what is known as a plasmid. Okay, now plasmids contain what? What do plasmids contain? Plasmids contain the antibiotic resistant. Is it required for life of the bacteria? If a bacteria doesn't have a plasma, will it die? No. Perfect. That is the other fact that you need to know, that this is not required for life. All this does is amplify the bacterial's ability to survive. Okay. So, with that being said, the genetic process by which this occurred is shown. Which of the following best describes this process? We've already seen by looking at this image that this is conjugation. So that's why the answer here is A. Conjugation. Okay. Any questions on any of these stuff? No? Well, good. It's plasmid DNA. So, plasmid is something that can be DNA. Okay, majority of the time it is DNA. Why? Because it has to incorporate itself back into the actual DNA to be transcribed into protein. Okay, so this plasmid will actually merge with the DNA of the bacteria inadvertently between times to produce the proteins of the plasmid. Okay, and then it will re-separate from the DNA and be its own separate plasmid again. Does that make sense? And this is why it's seen as more of a, and you may have heard it from Dr. Fernandez, as more of a expansion pack. Because literally it's fusing with the original DNA every so often to do whatever it needs to do, and then it separates again. And then is its own plasma particle by itself again. Okay. Now, another way that they could ask a question on this is they could bring up the concept of what that plasmid contains. So for instance, they could take a picture, or not really take a picture, but explain to you where a bacteria has a plasmid, okay? And then another bacteria, right, that is resistant. It's the same strain of bacteria that is resistant to it versus the other bacteria that's not resistant. And the reason why is because the plasmid has been incorporated into the DNA. Okay? And that's why the cells that have just the bacteria, and they're both cell lines, they're both the same, right? Is that the plasmid is incorporated into the DNA, which allows it to produce the resistant enzyme to then prevent from dying from the corresponding the antibiotic.
Yeah,
Okay.
yeah.
Good. Now, okay, so what's going on here? Question.
Yeah.
Okay. So I thought, so did I count the numbers wrong? So 1, 2, 3, 4, 5. Because it's 6. It's 6 half-lives, or 6 times it goes, right? So this is
Yeah.
1, this is 2, 3, 4
Where
to
is-
62. 4 is to 32. So then 5 would be to 64. Yeah, you're right. And then 6 would be to 128. Okay.
There is 64,
Yes, because it's doubled.
4.
So you just had to do it one more time because this was essentially 4 or 5. This was 5 here. I thought that. Does that make sense?
Yeah. Yes.
Okay. But the concept is still the same. It's just how many times you're going to do it.
Okay.
This right here is the big portion, right? To know that the generation time, because after you figure out how many generation times, everything else is just math. Right? So you need to first figure out the generation time and what the lag time corresponds with it, which is what this here is showing you.
64 times 4 times 200.
Good.
Yes. Yes.
All right. Perfect. So that's the micro MCQ. If you have any questions on any of these guys, please bring that up. 64 times 200. Oh, okay, because you're adding in the zeros is what you did. Okay. So that's why you have the 200 the 200 versus 2. So yeah, great. Because I'm telling you now that this concept of transduction and stuff is very important to know because those are the things that you're going to come across moving on. Now, I've also produced another PowerPoint for you guys to do. Where is that now? I just had it. The one that I thought was the one we were doing. That's that one. And the one was this one. So I've also have this one here that gives you the same stuff. So you can go over it. The concepts are the same here. Nothing's different. You have the answers. You'll have the breakdowns of everything and whatnot. So yes, you'll get that access as well. So you can go over those. Okay. But I'm telling you, knowing the genetics of bacteria and viruses is a must know. You have to know what mixing is. You have to know what masking is. Okay. You have to know what reassortment is when it comes to viruses as well. All those things are very important to know. Okay. Versus recombination. Okay. Transduction versus transformation versus conjugation when it comes to bacteria. Okay. Good. All right. Let's take a 5-minute break and then we'll jump into the Jeopardy questions. Sounds good? All right. Perfect. Yeah, and in there you'll see the pharmacology and the immunology stuff again. So it'll be a good kind of setup because I have that in there. But yeah, make sure you know the genetics of that stuff like we were discussing. Does anyone have any questions on that stuff? Because I have the PowerPoint that we can, or I guess a session thing we can talk about. So does anyone have any question on this stuff? Bacterias?
Hey, Michael, I actually had a question about
Yes.
cell-mediated versus humoral and like how does CD8 and CD4 cells play into it? I've been kind of mixing that up. Can we
Okay, yeah. Yeah, most definitely. I can go over that real quick.
Okay,
So,
cool. Thanks.
yeah, no worries. So let me go ahead and I will pull up because I have that here. I want to say, is it here? I think it's in the first day. Because I want to show you a good image. Okay. So the first thing is that we want to discuss is what the heck gets this thing started? Okay. So what happens at the very beginning, right? is you have to initiate the adaptive immune response. Okay. And at the adaptive immune response, you have various things that go on. So, for instance, this is happening at the tissue, right? So, in the tissue, you get exposed to various antigens. Okay. They get eaten up by dendritic cells that then travel via the lymphatic systems to your lymph nodes. Okay. In the lymph nodes, they activate either T cells to do their thing or B cells to do their thing. Now, you got to think that in reality, T cells and B cells are both getting activated. Okay? Because you got to think in the production of antibodies, like a Th2 response, you have to activate B cells. Right? So I don't want you to think of it as this is solely just T cells or this is solely just B cells. Think of it as adaptive immunity is being activated. And within that case, T cells have their two different cases where it's CD4 or CD8. Right? Now, between those two, CD4 and CD8, CD4 is the T helper cells. These are the guys that help with increasing the innate immune response with macrophages, and CD8 are more cell-mediated immunity, right? They go and they actually kill intracellular bacteria or intracellular viruses. Okay, good so far.
Yeah, that helps. So intracellular, does that mean like it's incorporated into our cells, or I kind of a little confused on the difference between extracellular, intracellular.
Okay, yes. So the difference between the two is that just like you were explaining, yes. So intracellular is a bacteria or virus that's essentially inside the cell. So it has found a way to exit the phagosome if it's a bacteria. An example of this is TB, okay, tuberculosis. You have various other guys that do it as well. But TB is a well-known one. And an extracellular bacteria is this one that just sits on the outside of the cell. Okay, so these are the two different things. So this guy here, you're going to have more of a Th1 response and CD8 response. Now, CD8 really comes into play with viruses because viruses do not replicate by themselves, right? These are dead organisms, right? They're not alive. They're parasites to our cells because they inject their viral or DNA viral genome into our cells and then replicate in our cells, right? So these viruses, when they replicate in our own genome, they present on MHC class 1s. This is what allows CD8 to get activated and kill them. Okay? Does that make sense? Versus this guy, whenever you eat it, it's presented on MHC class 2. Okay? Good so far. Okay, great. So this is the difference between intracellular versus extracellular. And you can also see how you're presenting them on different MHC molecules. So you can kind of see how now we're going to separate what type of cells we activate. Okay? For instance, with extracellular bacteria, you mainly undergo a Th2 response. Oh, no, not Th2, Th17. Th17 response. Okay. Now, Th17, that looks like 12. Th17 is something that helps with producing neutrophils to the area. Okay. Now that you have an idea of what is intracellular versus extracellular, let me show you. No, not there. Let me show you the different classes of T helper cells. So these are the different classes of T helper cells. Okay. T helper cells, if you have any MHC class 2, right, they're going to have different pathways they're going to activate. All right. One, if it's intracellular, you're going to activate Th1 cells, and these guys are then going to do their action. Okay. So once again, think about what is the organism. If it's a virus, if it's a bacteria, if it's a fungus, if it's a hypersensitivity reaction, right? These are the big things you have to think of what is the primary reason that this patient has a reaction, right? So in this case, it's due to an intracellular infection. So this could be TB, for example, which is why interferon gamma is a big guy. Okay. Or this could be a virus. Okay. And a virus would also go the same path, and you would activate Th1s that helps with CD8s. Okay. And their function. So that's how this works out. Does that make sense so far?
So you're saying like T helper ones can activate via CD4, CD8?
So T helper 1s come from CD4s. CD4 has various subclasses. Okay. The only one that doesn't have a subclass is CD8. CD8 just becomes cytotoxic T cells, and that's it. CD4s have various subclasses. Okay. And that's where you get in the Th1, Th2, Th17, and Treg, which is something that you only see when you have that too strong of a bond when you're undergoing maturation in the thymus. Okay. So whenever you think of viruses, always think CD8, cytotoxic T cells. Okay. Because you're thinking of what is infecting them. Viruses, CD8. Okay. Anything that would present on MHC class 1, right? So abnormal human cells is what you're thinking of. Cancer cells is another example. Okay. Not a virus, but it's a cancer cell. Okay. It could be a bacteria chilling inside of it, like TB. Okay. So you see how it's more of what they're infected with that determines it. Okay. All right. So this here, so this one here would be intracellular. This one here would be allergies. This one here would be extracellular. Okay. And then B cells are activated always throughout the process, right? Because B cells and T cells get activated. It's just which category they become when you look at a T helper cell. Because this is always intracellular / cancer cells. All right, good. Okay, so now that we went over that, I hope that clarified that a lot more. I can make you a little video to go in more depth if needed. I have no issues with that. Now, the next thing I wanted to do is jump into the Jeopardy. So let me do that. Here it is. Now, perfect. Play. All right. Woo! Now, here's Jeopardy now. So helper T's activates B cells too? Yes. So helper T cells activate B cells to become different subclasses of B cells, of like plasma cells, right? So for instance, helper cells release interferon gamma that is needed for changing plasma or B cells, I should say, into IgG secreting B cells. Okay. And this is where the CD40 ligand to CD40 is very important. So, for instance, what ends up happening is a T helper cell. So if this is a T helper cell, all T helper cells have one cell receptor on them that they must have. And this is known as CD40 ligand. Every T helper cell has a CD40 ligand. Okay. And this CD40 ligand allows them to do their function. Okay. They go to a B cell and they release various interleukins or interferon gamma. Okay. And allows these B cells to undergo class change. Or it goes to a macrophage. CD40 ligand binds to the CD40 of the macrophage and allows them to then undergo more respiratory burst with interferon gamma. Okay. And T helper cells even assist in replicating CD8s because T helper cells release IL-2. IL-2 stimulates CD8 to self-replicate. Okay. So this is how T helper cells essentially do their function via CD40 ligand. Okay. And they do it at these various cell locations to allow them to do whatever they need to do. This is in the lymph node. This is in the tissue. Okay. And this one here also is in the lymph node. Does that make sense? Yeah, no worries, no worries. So this CD40, and this is why when you have a disease that affects CD40 ligand, you have a variety of symptoms that you present with. But one of them that's the most apparent is this B cell not class changing. Also known, yes, as hyper IgM syndrome. Perfect. Perfect. Because it helps them with the class changing. Now, you do have to make sure that you know which ones do what. So IL-4 is for IgE. IL-5 is for IgA. And then interferon gamma is for IgG. You do have to know that as well. All right. Good now? I'm loving the questions that you're asking. Okay. All right, Jeopardy. So, in Jeopardy, let's pull this up. Let's go to the corresponding concepts. So, you got different classifications here. You got immunodeficiencies. You got immunosuppressants. Hot T-bone is interleukins and cytokines. This is like inflammation. Okay. Don't spill the T's. This is more like your T cells and B cell stuff. You're so hypersensitive is just your hypersensitivities. And then miscellaneous is just all the other stuff, right? So with that being said, we can do this one or two ways. One, we can play it as an actual game where you guys then decide what you guys want to go with, what you guys want to choose, and we'll go it that way. Two, we can just go straight forward and go through them top to bottom. How do you guys want to do it? Do you want to just do top to bottom? Or do you want to actually play it as a game? I'm cool with playing it as a game. Okay, we'll play it as a game. So let's do this. I have your guys' names. So let's start from the very top. And I'm sorry if I say your names incorrectly, but let's do, is it Valeria? Is that how you pronounce? I'm probably butchered your name, which I'm sorry. I really am. But which one of these do you want?
No, you said it perfectly. Can
nice.
I do, yeah, you said it perfectly. Can I do the never immunodeficient 200, please?
Okay. So you guys have already gotten these questions. So with that being said, what did you answer on this one?
I did C for this one.
Okay, great. Perfect. So C is the answer for this one, right? Because essentially, what is going on? Like, essentially C's answer because of what?
It says that there is no CD3 cells. It's not
Okay.
detected. So I also checked, it's 75% neutrophils.
Okay.
I figured B cells were fine because of the CD19 was present. And then the yeast infection, like the recurrent, that it hasn't been able to be cured.
Okay. So why did you cancel out A and E?
So that's usually like present in B cells as well. So, but
Okay.
in this case, B cells are present.
Okay.
And then same thing with RAG. If RAG1 and RAG2 are absent, then you wouldn't have your B cells as well.
Good. Very nicely done. So that is why this answer is once again C. This is one of your skids, right? IO2 is the big one for your skid. Can you tell me, is this X-linked dominant, X-linked recessive? Like, is it autosomal?
I think it's X-linked recessive. I'm not sure though.
Good. So this is X-linked recessive, right? The other two are autosomal recessive. So this is where you get into things like adenosine deaminase deficiency and RAG gene deficiencies. Okay. So great job. Okay. So anyone have any questions on this one? No. Okay. Then my question to you now is, what other conditions can cause a mixed immunodeficiency where you're not only infected of bacteria and fungal infections, what other mixed diagnoses do you have?
You asking her?
Anyone?
Oh, when you say mix, you're talking about,
T and B cell is affected.
okay.
T and B cell. So I just gave you an example earlier with CD40 ligand. Remember, not only are the B cells affected in there, but I showed you on the bottom with CD8 also being affected. So that is known as a mixed.
Okay.
T and B cells get affected there. Okay. The other two is ataxia telangiectasia. And then the final one is Viscaud-Aldrich syndrome. Okay. What other symptoms would you expect to see in someone with a skid that's not presented in this vignette?
The thymic shadow. Absolutely.
Perfect. The absence of the thymic shadow. Good. Would you see anything in the lymph nodes, for instance? Would there be something different there? What's going on with the lymph nodes in this individual? So if you have no CD3s, where
Right.
do CD3s present themselves in lymph nodes? The paracortex. Perfect. So the paracortex would be absent in this individual. Okay. You would only have the germinal follicles. Does that make sense? Great. All right. So, yes, Piles is also is a big player with T cells. Yep, agreed. In the spleen. So let's move on. So, back to the panel. I think I have to do it this way to get it to go away. Back. Oh, okay. I think it doesn't actually show it on here. Okay, so next one. Let's do John. What do you want? Okay.
You're so hypersensitive.
Which one for hypersensitivity?
Yes, you're so hypersensitive.
Which one?
Let's start from the beginning. 200.
Okay, 200. All right. So what did you choose for this answer?
Oh my gosh. On the spot. Hmm. Um, this is the same mechanism like what's that one for thyroid? Oh my god, because I did this on first time looking at it,
So
but
you're
I still
thinking
can make it out.
of myasthenia gravis?
Yes, yes.
Okay.
That's exactly what it is. Yes.
Okay. I agree.
The acetylcholine cannot reach the receptors. So it is being pumped out by the body, but the receptors are being blocked by the antibodies.
Yes.
So with their block, you are looking at substantial muscle weakness
Yes.
because no transmission.
Yes.
So A.
Yes, perfect. So it's A, antibody binding directly to cells and reducing functionality, right? So which type is this? 1, 2, 3? Type 4?
It's always these jokers. Oh my God. Let me see. Hold up. Oh my gosh. Can I do 50-50? Can I ask a friend? I forgot.
Yeah, anybody can answer this one.
Okay.
Yes, it's type 2. Perfect. So this is type 2, hypersensitivity.
Thank you, team.
Good. And type 2 hypersensitivities are whenever it binds directly to cells, right? And one of those guys that you need to make sure that you don't forget about is the Combs test. Okay, Combs test. Because this is going to come in the bigger play in test 2, CAS 2, when you do HEMONC. Okay, so Combs test is very important for you to touch base and understand now, because you're going to expect you to know it when you go to CAS 2. Okay, so does anybody have any questions on the Combs test before I move on? You know
So
the difference
for
between a
direct,
direct and an indirect.
yeah, I was gonna ask, it was direct where you're testing like, or like indirect is you're testing for antibodies, and then direct is that like you're testing for the receptor? I'm kind of a little confused on which one tests which.
Okay, so the direct is testing for the actual antibodies binding to the cells. Okay, so for instance, when you do a direct, you're seeing if the patient is currently exposed to whatever antigen that the antibody is binding to. So for instance, in let's say pregnancy, right? And with the erythropoiesis fetalis, right? Where the baby dies, right? This is where Combs test comes into play. They do a Combs test in that individual who's actively having cell death in the baby. That would be a direct Combs test, because they would see in the baby that the red blood cells are currently being ruptured and the antibodies are currently bound to the RBCs in the baby. Okay, does that make sense? Versus an indirect is to see if the mom was ever in her past having a baby that was Rh positive, which then exposed her and now has antibodies and causes the next baby to be at risk. Okay? So just like you were saying with the indirect, that is 100% correct. You're seeing if there's antibodies present versus the direct. I hope I clarified that.
Question, Doc. So would they do after the mom's first pregnancy, would they automatically do, if they haven't talked to the father, identified the father, God forbid, would they automatically do an indirect Combs test just to rule out any future possibilities of exposure?
So if they didn't know,
Yes.
like let's say that the baby came back Rh positive and mom's Rh negative, right? Then they
Yes.
would do an indirect at that point in time.
Right. That's right.
See if the mom has produced Rh positive antibodies.
Okay. And okay, there we go. That's what I was trying to figure.
Does that make
God.
sense? Because
Yes.
the baby wouldn't have any, because the baby is the first baby, right? And the first baby never has RH exposed,
Right.
right? It's
Okay.
always the second baby and the subsequent babies that you
That's
have
right.
to worry about with a direct Combs test.
So that's the first sensitization from the first
Yes.
baby.
Yes,
Okay.
exactly.
Okay.
Perfect. All right, good. Any other questions on that before we move on? Okay, we're good to go then. Okay then.
I think Shirley said she wanted to go next, Doc.
All right, so just like you guys were saying, this is a type 2 hypersensitivity. Type 2 hypersensitivity is broken into two classifications, cytotoxic versus non-cytotoxic. This here is a non-cytotoxic one, meaning the cells are not dying. In the erythroblastic fetalis, with the Combs test, that is known as a cytotoxic one, okay, where the actual cells are dying off. Okay, this is also the same scenario with hyperacute graft rejection, which is also a very big thing to know. All right, good. So now, with that being said, we've already done this. So the next one on my list, yes, is Shirley.
Thank you, Brother John. I would take you're so hypersensitive 1,000. I'm a high roller.
Okay, so 1,000. There we go. So for this one, what did you answer?
I did C.
So you did C. Why?
Because here we're talking about a tetanus booster vaccine. And if you look at it's saying about cause swelling and inflammation within 24 hours.
Okay.
And I do know that from type 1 to type 3 is your antibodies, and this being your immune complex formation here, and type 4 is cytotoxic T cell.
Okay. So you're saying C is the answer to this one because
Yes,
you're thinking this is a type 3.
Yes.
Do you know what type of reaction this is called? Arthur reaction. Perfect. Yeah. Arthur's reaction. Now, my next question is this. If this patient never got a booster, like in his past, he never was a tetanus vaccine individual, and then this is his first tetanus vaccine, is it still possible to get type 3 hypersensitivity?
If he never had it.
He never had a tetanus booster or a tetanus shot in the past. He never had it. This is his first time getting a tetanus. Is C still possible?
Yeah, I don't think so. I think
no. Perfect. Great. Because
first.
Yes, so this is Arthur's reaction only occurs with repetitive exposures to a foreign antigen. Okay, in the subcutaneous tissues. So, for instance, this is what happens. Your body produces antibodies. You may have seen this in your notes. Your body produces antibodies. And these antibodies bind to foreign antigens that you inject into your body. So another example of an Arthur's reaction would be something like insulin injections. Okay, so you can end up having an individual that has type 2 diabetes and gets insulin injections, and then all of a sudden their insulin isn't working as much because you have this reaction occurring in the tissues that's causing the insulin to not be absorbed into the blood like it should. Okay. So that's essentially what's going on, is that you're forming these antibody complexes that then activate your corresponding immune system to cause vasculitis at that location, which is why it's swollen and it's red. Okay. What interleukins are highly expressed at this site?
Complement?
So complement is more of if it's inside the blood vessel. So yes, complement is a big player. I'm not downplaying complement here, but here I'm not thinking of complement. I'm saying interleukins.
Okay.
So complement isn't an interleukin.
We're talking about
IL-1, IL-6, perfect. These are your inflammatory guys. TNF alpha, these guys are your inflammatory guys to really open up the blood vessel and allow inflammation to occur. Good? Any questions on that? No? All right. Nicely done, Shirley. See you going big. Next one. Let's do I'm gonna hopefully I don't say your name wrong. Is it Prajay? Is that how you pronounce it? Good. So which one do you want to do? And if you're not up for it, it's fine. You can just say pass and I'll choose for you. Okay, 200. So what do you choose for this one? Would I miscellaneous for 200? What's going on? Perfect. So the answer here is C, generation of bicarb. So, not bicarb, hydrogen peroxide. So essentially what's going on here is this individual is presenting with NADPH oxidase defect, right? And as a result, you don't have the ability to produce H2O2 or hydrogen peroxide. What about this guy, which is also a condition that you should know? So chronic granulomatosis disease is the guy that you're thinking of here in C. So yes, that is correct. But D, myeloperoxidase. Yes, myeloperoxidase deficiency. How do they present? Yes, perfect. A lot of fungal infections being candidiasis. I love it. That is exactly how you present with someone who's absent in myeloperoxidase. Okay, good. Any questions on that? No, you're good. All right, then let's continue with the scenarios. So back to the panel. So we did this for 200. So our next guy is Isabella. Hopefully I said your name is right as well.
Yeah, you did. I'll do hot T-bone steak for 200.
Okay, 200. All right, so let's see what this is. So what do you think this is?
So based off the fact that it's a monomer and the keyword for me was crosses the placenta, I went with D.
Yes, perfect. IgG. This is great. This is a guy that crosses the placenta. What is the antibody that you would use to see if the baby was actively infected from the mom? Let's say mom had HIV, baby's born, and you want to know if the baby has HIV. Yes, IgM. IgM. IgM is always the guy that's present when you have an active infection. Okay. So, with that being said, IgM is going to be present in the baby, and IgM does not cross the placenta. So you can't misconstrue it as being the mom presented the IgM and then gave it to the baby. That's not possible. The baby had to have made the IgM. Okay. So that means that the baby was actively exposed to HIV. Okay. Does that make sense? Which one of these guys has the J chain? IgA. Okay. Is that it? And IgM. Perfect. So IgA and IgM are both components with the J chain. They form the pentamer or the dimer format. Which one of these guys is the lowest? Yes, in the serum. Perfect. I'm thinking of the serum. Exactly. Yeah, Shirley, great. IgD, you never secrete IgD, right? But let's say of the guys that you do secrete, which one of these would be the lowest? Of the ones you do secrete. So getting rid of IgD, which one would be the lowest? IgE. Yes. Allergic reactions. Perfect. IgE is the lowest of them all. IgA is actually the highest one produced that your body does is IgA. Okay. IgG is the highest in the serum, your blood. So this is the highest in the blood. This is the highest produced overall. And this is the lowest. Perfect. And then of course the aspects with crossing the placenta. All right, let's keep moving on. Good job. So now, let's see, I don't want to miss anyone. Is there anyone else I may have missed? Because I don't see anyone else on my list. So maybe that's it. No, there's someone missing, I feel like. Okay. So Shirley knows. So let's go back up to the top now with Valeria. What are you saying?
Can I do the immunosuppressant for 100?
Okay. Immunosuppressant for 100. Oh, for 200?
Yes, please.
Okay.
Or yeah, that's fine. So I think, give me one sec. I think I did A for this.
Okay. So you did A, blocked cytokine response. Can you explain to me why you did A?
So they're using sirolimus,
Okay, perfect.
like a sirolimus eluting stent, and we know that it binds to the FKBP12 to
Okay.
block the mTOR. So mTOR leads to the proliferation of genes.
Okay.
So if that is blocked, then you can have your cytokines like the inflammatory cytokines being released.
Okay.
Right?
Yes, you are correct. So I'm going to throw a wrench in your thought process there and say, but tacrolimus inhibits the NF-kappa beta, and that also deals with producing interleukins. Is that not correct?
Right.
So would that also be a blocked cytokine response? Yes or no?
Yes, it would.
So, no. Now, the reason why is because blocked cytokine response requires one thing. IL-1 or some cytokine, like IL-2, had to have bound to a receptor, which is what happens in sirolimus. IL-2 binds to a receptor, and then sirolimus prevents IL-2 from doing its function. So that's why it's deemed a blocked cytokine response. Okay, does that make sense? Yes, no, maybe so. Okay, great. So, yes, so A is the correct answer. And just like we discussed earlier, IL-2 is the guy. Sirolimus blocks mTOR, just like you said, perfectly. And this is why it's named as a blocked cytokine, because IL-2 is the guy that's actively activated first, and then you prevent it. So if you look in the surrounding area, you'll still have high levels of IL-2. In this scenario, you have low levels of IL-2. So that's the big difference that you need to make sure you don't mess up on is one would actually have no IL-2, and one would actually have IL-2 in the surrounding area. All right, great. Okay, let's keep going on. So next person, let's move on to John. What are you saying?
Nobody's touched. Well, you know what? I'm gonna wait for somebody to touch it too. Let's go for 400 for You're So Hypersensitive.
Okay, 400. You're So Hypersensitive. What'd you put down for this one?
Let me see. Blah 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 blah. This is my first time ever having some little concern issues. So okay, let me see. Why so look like demon? All right, interior thigh. This looks like delayed sensitivity.
Okay, so you're saying delayed sensitivity.
I could be wrong. I'm just shooting it off. Okay. He received all his scheduled doses. This is second dose diphtheria, minister right quads. We're looking at what's that called? Wheel and flare. That's what I'm thinking. Wheel and flare. I'm thinking it's E, but I could be wrong. I'm thinking E. I don't know. I could be wrong.
Okay, so you're saying T lymphocyte mediated hypersensitivity. So you're thinking this is a type 4.
Yeah, I might be wrong though. I might be wrong.
So now my question is this.
Oh gosh.
In type 4 hypersensitivities.
Oh my. Because okay. Oh man. Okay.
In type 4 hypersensitivity, what cells do you see present?
Type 4 is T cells.
T cells or
Yes.
lymphocytes, right?
Yes. Yes.
You see that in the biopsy.
Oh shoot.
No, you do not.
Neutrophils. So it's not there. So it cannot be type 4.
Yes, it cannot be type 4.
Oh my gosh. Neutrophilic infiltration. Oh. Let me read. Okay, let me read again. Hold on, Doc. Nope.
Want to buy a vial for 500?
Yeah, I'll buy a vial 500.
So anybody else can help out with it?
Yes, I can help them out.
Type
Type 3
hypersensitivity.
hypersensitivity. The answer is B, because we're looking at the complement deposit.
There you go, Shirley. There you go.
Okay.
So yes,
All right.
that's
Okay.
exactly what's going on here. So
Yes,
this
type 3.
individual has gotten their, so you got to think, first of all, this patient's all the way up to date with their immunizations. So they've gotten a lot of these immunizations already, right? So with you already being exposed to these immunizations, and then all of a sudden you get your second round of immunizations, you have a risk of getting immune complexes formed and doing the arthros reaction that we were just talking about.
Arthros.
Where the immune complex is formed due to the antigen epitope that you had injected the patient with in the subcutaneous tissues, and it presents with skin necrosis, neutrophilic infiltration, and complement deposition from the immune complexes.
And I should have saw that. I read it too fast.
That's why B is the right answer.
Thank you, Shirley.
You're welcome.
Right.
Anything for the home team.
Job. Great job. Very great job. Okay. Okay, so next we have Shirley. What are you going to say?
Since we're still over there, I can do You're So Hypersensitivity 800.
Okay. So for this one, what did you say?
I said B, type 2.
You said type 2. Why?
The reason why I said, because as I look at the question stem and we see all that fluff up there, but I see that he had taken amphetamine, and then I looked at, the erythemas of the skin, the clear center, arthritis, the small sustaining nodule. And so that what led me to, it can be drug induced. That what led me to.
So you thought this is drug induced due to
I did.
acetaminophen.
I did. Am I wrong?
So this is a patient with rheumatic fever, which is why that's given up top,
Oh,
because you don't
yes,
know that yet. You don't know the
that's right.
diagnosis of rheumatic fever yet,
Right.
which is why it was given to you. But
Okay.
in these types, rheumatic fever was stated to fall into one of these categories. And rheumatic fever essentially falls into category B, so type 2.
Mm-hmm.
Now, with that being said, with rheumatic fever, what ends up happening is you produce antibodies to strep pyogenes. Okay. And as a result, you attack your own cells. Okay. Now, my next question to you is this: what autoimmune disease or explanation explains this? What term is this called? When you produce antibodies against the bacteria and then you inadvertently attack your own cells.
Autoimmune disease, huh?
No.
What we call autoimmunity?
So autoimmunity is a type of category, right? Like a different, like it's a concept, right?
Mhm.
So it's known as molecular mimicry.
Oh, that's right. That's right.
This is a
That's
big word you know to need to
that's
know.
it. Yeah.
Okay. Molecular mimicry. Is this the same as autoimmune disease?
No.
No. Well, that's why it's not called autoimmune disease, but how is it different? Why is it not called autoimmune disease? What is the basis of autoimmune diseases? Is that you're
Antibodies.
attacking self,
So,
right?
Yeah.
You're producing
That's it.
antibodies to self. This is producing antibodies to foreign antigens. You see the difference? One is attacking foreign antigens, and then human self is just a bystander. Versus autoimmune disease, where you're actually attacking yourself. Okay? So that's
Makes
the
it.
big difference between molecular mimicry and autoimmune diseases. Okay? Good.
question, Doc, question, while we're on this subject.
Yes.
So, molecular mimicry would have no association with negative selection failure.
Yes. Molecular mimicry has no issues with negative selection.
Okay.
Perfect. The thymus is working perfectly fine. It's doing everything it needs to do. It's just because of antigens looking so similar to your own cells. Yep. Perfect.
So I have a question.
Yes.
As I look at the PowerPoint for molecular mimicry for the fungal, it says, and you can give me clarification on this, it
Yes,
was
most definitely.
delayed type hypersensitive. You know, he made mention of that in class.
So his example of talking about it being delayed is because what you're doing is you're injecting fungal antigens into the skin.
Okay.
Okay. And the fungal antigens being injected into the skin is seeing if you have been exposed to Candida in the past. Correct?
Okay.
I'm thinking this is that example that he's talking about.
Okay.
So
Okay.
that's exactly what you're doing in that example. And
Okay.
the guys that fight off funguses are Th17s,
That's true. Uh-huh.
right?
That's true.
So that's the adaptive immunity response. So
Right.
that's why that's that's a type 4 hypersensitivity.
Okay. Thank you for that.
Yeah, no worries, no worries. So that's different than molecular mimicry.
Okay. All right.
Okay. Good. So the next question, let's move on to project. Dang it. I said it right the first time. I don't know. I said it this
Just call him PJ. Just call him PJ.
Okay. So
Go ahead, project. Go ahead.
which one? Okay,
Go
PJ.
go for broke. Go for broke, project.
Okay, which one? Let's finish on. Okay, so 800. So, oh, did we already do 800? Yeah, we already did 800. Maybe it's 600 we didn't do. Yeah, 600 we didn't do. Okay. 600. What did you say about this one? 6-year-old in duration, sign of bee sting. So this is the big thing you have to be mindful of. Which of the following explains in duration at the site of the bee sting? So the big thing that you have to understand here with induration at the site of the bee sting is you're going to be making various things mad, right? So bee stings causes you to have inflammation at the site, right? So you get inflammation. So that's positive inflammation. Now, if you end up getting swelling of the face, this is systemic, not localized. Does that make sense so far? So systemic swelling of the face happens due to histamine and mast cells. That is correct. But inflammation at the site, this is why I always tell you to make sure you don't forget about this guy. Inflammation, macrophages, cytokines, always this way. It does not change. Okay? Which is why this answer ends up being B instead. Okay? They threw in here mast cells and histamine because you would have tripped up on it if you thought, oh, histamine, type 1 hypersensitivity, these are the guys. Yes, for systemic inflammation and swelling, but localized is always macrophages and cytokines. Okay? Now, this is different if, let's say, you ate shellfish and you are allergic to shellfish. What is the result of induration and swelling in this individual? What would be the result? Would it be histamine or macrophages and cytokines?
Histamine.
Yes, histamine. Perfect. So that would be more of a histamine and mast cells. Okay, because there's no actual localized trauma. Okay. This is why they said at the site. All right. I hope that clarified for you.
And also because they have induration, that would make it not be the mast cell and histamine, correct?
Yes,
That's why
that as well, because induration is textbook
right.
for inflammation.
Right.
Yes, that is correct. All right, good. Any other questions before we move on? Yeah. So when you think of induration, think of it as redness. Literally the definition of inflammation. It's red, it's pain, it's hard to touch. Right? This is the definition of induration. Okay, great. Let's keep moving on. So let's do Isabella. Which one do you want to do now?
I'll do
Well, go ahead.
don't spill tea for 800.
Okay. You said don't spill the tea for 800?
Yeah. Yeah.
So what did you say for this one?
NK cells.
NK cells for this one. So why did you say NK cells?
Because it's specifically asking which cell type is the most important for clearing the infection in the patient. And the NK cells are responsible. It was a pretty straightforward question, I think.
Yeah. So so with that being said, let me ask you, what type of infection is this?
I know it was in pelvic. It sounded like pelvic inflammatory disease.
Because you got these classifications: intracellular, extracellular. Maybe this is like an allergy, but this isn't allergies.
No.
So you're down to intra or extra?
Intracellular?
Yeah, so this is intracellular. Now, NK cells, yes, they do kill cells that don't produce MHC class 1s. So that is correct. But NK cells are not responsible for making sure if a cell, let's say this is a cell here, and it has an MHC1, but on it, it's a virus antigen. It's not responsible for seeing if there's a virus on it, though.
Hmm.
Right? NK cells are just responsible for seeing if MHC is even present. So with that being said, this ends up being D, Th1 lymphocytes, because Th1 lymphocytes are very important in producing CD8 cells. And CD8 cells are the guys that are responsible for killing intracellular bacteria. So that's why this ends up being a Th1 lymphocyte. Does that make sense?
Yeah.
Okay. So what would complement be responsible for clearing? What would complement be responsible for clearing? So this is responsible for clearing gram-negative bacteria. Okay, gram-negative bacteria. It's also important in clearing immune complexes. That is completely correct as well as a little bit with opsonization. But complement is really important in gram-negative. So much so that if you lose complement, you get gram-negative infections. Not just any bacteria, but specifically gram-negative. Okay, so that's what complement is really important in killing. Okay, is gram-negative. Antibodies, like, is very good for both gram-negative and gram-positives, as well as viruses as well. Th2 lymphocytes, what are those very good for?
Parasites.
Parasites. Perfect. Parasites are very important with Th2. So, with that being said, this is the kind of graph showing you Th1 versus Th2. Make sure you understand what stimulates Th1s, okay, such as IL-12, interferon gamma, right, versus Th2, things like IL-2, IL-4, okay, what they produce as well. Make sure you remember those. And whatnot. And then Th17 is very big for extracellular bacteria, right? Because it brings in neutrophils. And neutrophils are always the first responders to an infection. Okay, neutrophils, acute inflammation, Th17. Okay, neutrophils. All right. Okay, let's keep going. So, with that being said, we're now past 7. So we can do this one of two ways. One, we can meet up again to finish off this PowerPoint, which I'm cool with. At that point, I'll just go through it with you. You know what? Let me tell you. So let me back out of this. Let me tell you the big things to look at for this PowerPoint. So make sure you know the immunodeficiencies. Okay, primary immunodeficiencies. Make sure you know them. Neutrophils, I don't doubt for a second that they're going to be on there. Okay, let's see here. Know how complement works, right? Know the different portions of complement. All the A's, C3A, C5A, C4A, these guys, anaphylatoxins, increase in the aspect of inflammation, right? This is also something that's very important to know. Making sure you know, what does MAC do? It kills gram-negative bacteria. That's what it does. That's what it's responsible for. Okay? Versus C3B, which is very important for the other components like forming of the MAC, okay, or being an opsonin, okay. Let's see here, what else in this thing. With the drugs, make sure you know those 3 classifications, right? You need to know the mechanism of action. You need to know the side effects of the drug. And then lastly, you actually need to know like the name of what you're doing, of whatever the drug is, right? So you need to know it's cyclosporin, and then the mechanism of action, and then finally the side effects of the drug. Those are the 3 things you have to know going into this quiz on Monday. Okay, you have to know these things, because if there's going to be any question on farm, it's going to be one of those 3. Okay, let's keep going. Let's see here. Yes, big thing. What are the inflammatory cytokines? Okay, you have to know what these guys do, okay, as well as what cytokines are released to stimulate B cells to produce certain cytokines. I already went over that, right? IL-6, no, IL-5 does IgA, right? IL-4 does IgE, interferon gamma does IgG, and then IgM is just always present, right? This aspect here with actual movement of the cells into the tissues, okay, this is very important as well. I can see this possibly being a question on your quiz. And what stimulates these guys to be present? IL-1, TNF alpha causes things like E-selectin, P-selectins to be present on the endothelial wall. Okay, Salo-Lewis with that aspect of things. Okay, you got the leukocyte adhesion deficiency. Okay, with CD18, that's very important to know. All right, what else? We already talked about the antibodies, which is very important. Vaccinations. With vaccines, make sure you know conjugated vaccines. Out of all the vaccine stuff to know, conjugated vaccines is most important because this is what connects B cells and T cells together in vaccines. Okay. And it's also why B cells only have IgM when it's a polysaccharide versus IgE, IgG, and IgA if it's a protein antigen. Okay. So you have to understand how B cells get activated to even understand how conjugated vaccines work. Okay. So that's why I see conjugated vaccines to be the highest yield when it comes to vaccines. Like you're going to see a question on it. Now, this here, with the actual process of T cells and B cells, with the maturation and development of them, make sure you understand how RAG1, RAG2, and TDT work. You don't have to know the intricacies of them, but at least know that TDT adds nucleotides, right? And RAG1, RAG2 is responsible for the rearrangement. Okay. And it's always D to J to V to D to J. All right. What was the 2 somatic again? I don't know what you mean by the 2 somatic. Be a little bit more specific, and then maybe I can clarify because I'm sorry, I don't know what you mean by the 2 somatic. Let's keep going. Where we talked about that hypersensitivities.
Recombination and somatic hypermutation is what you're talking about, John?
Yes, thank you. That's what I was talking about. Yes.
Somatic recombination and okay. We're talking about after you've been exposed to the antigen and you're in the germinal follicles and you're increasing affinity of the antibodies. Is that correct? What is that what you're talking about?
Yes, that's it.
Okay. So yes, that is very important, the affinity maturation and somatic recombination, but know it in the sense that where it's occurring in the lymph nodes in the germinal center. In which germinal center? In active ones. Okay, so they're secondary germinal centers, not primary germinal centers, because primary germinal centers are not active, right? So you're not going to undergo somatic recombination and affinity maturation. Okay. And then the other thing that you need to make sure that you know is that despite affinity maturation and somatic hypermutation, you don't change you do not change the one antigen that you attack, right? It doesn't make it so all of a sudden you can attack multiple antigens or something like that, right? You still only attack one epitope despite undergoing somatic mutation and affinity maturation. Okay, conjugated vaccine is combining of certain bacteria or viruses together to make antibodies/memory, since one may not elicit memory itself, right? Yes, so in conjugated vaccines, that's a great question that you brought up. So in conjugated vaccines, you essentially have a polysaccharide, okay, portion, and a protein portion or amino acid. Okay, so you have both portions on a conjugated vaccine. Okay, the polysaccharide portion by itself undergoes T-independent activation of B cells, while the protein portion causes T-dependent activation of T and B cells, right? So how this works is when you expose someone to a conjugated vaccine, portions of both the polysaccharide and the T-dependent protein is exposed on MHC class 2s. And as a result, you're allowed to formulate memory for both the polysaccharide portion and the protein portion. Okay? Make sense? Okay, perfect. Good. So, and that's just making sure that you make sure you remember that this is always IgM related, while this one can switch to IgA, IgG, and IgE, being T-dependent. Okay? All right. So, with that being said, I'll stop there. I will give you the PowerPoint for the Jeopardy so you can look over all the other ones, and whatnot. Do you guys want me to do another session? I'm okay with doing another session tomorrow to finish off the Jeopardy, or are you good just going over it yourself and then having it on Monday? I think I'll have a session, and then if you want to come, you can come. And if not, it's okay. Okay? But in the session, I'll just go straight through them, and I'll just point out little details or any confusions that you have. I'll answer them. Okay? I think that's what I'll do tomorrow. So the time for that will be the same time. Okay, it'll be 5, and we'll only do about an hour, 5 to 6 tomorrow. Where I'm literally just gonna go straight through the Jeopardy, answer any questions that you have on it, and then we'll be done. Okay. All right, guys. So if you're going to show up tomorrow, I'll see you tomorrow. If not, it's okay. It'll still be recorded either way. So if you don't show up, you can still watch it via recording, and whatnot. So yeah, I hope this was helpful. I hope you guys do very well on your quiz. I know you guys will do very well on your quiz. Because we've been really harping on a lot of these concepts all the way through these days, right? And really doing questions together and like answering concepts. The one thing I would say is if this quiz does not go as well as you wanted it to, it's okay. My advice to you is to interact with me more. What I mean by is that I want you to tell me what you're struggling with. Okay? Even outside of the sessions that we're having. Because that allows me to help you between sessions. Because essentially, I only have you for 2 hours. Right? I mean, or 4 hours if I have you twice in 1 week. Yes, 5 to 6 tomorrow. I'll send you guys a link. So me being able to answer all your questions and confusions in those 2, maybe 4 hours, depending on what it is not an easy feat. It's easier for me to answer your questions in the, 100 and plus hours through the week while you're having the issues. Okay. So that's what I advise to you. If this quiz doesn't go as well as you want it to, it's fine. No worries. Just communicate with me what your struggles are throughout the week. Okay. And then we can formulate up videos together and we can work through the confusions. Because I don't want you guys to not excel. I want you guys to excel not only on the quizzes, but on your tests, right? And then even going on, like being a physician, I want you to be able to excel and be like, yeah, I really understand this stuff. It wasn't just memorization when I was in Med 3 or, moving on into Med 4. So that's ultimately the goal, right? It's not just to know it now, but to know it for your job as a physician. So, so don't hesitate to, talk with me because I'm here for you, right? All right. So I'm going to end this call and I'll post the recording online and I'll do the session tomorrow at 5 to 6. I'll send the link in the WhatsApp chat. So even if people want to come that aren't even in a group, it's fine. I don't care. But yeah. So I'll see you guys tomorrow if you go. Have a nice one, guys. Bye.